This is Terry Ciesla. The company is ScribeEMR. We're based out of Boston. Myself, I'm down in Clearwater, Florida. And then we've got offices spread across India. But there are some handouts available. If you look at the GoToWebinar dialog box, you can see there's some drop downs in there. So at any point in time, you can actually download some of the information. What you'll find in there is an outline, a documented outline of the workflow. Of course, we're going to talk about that in just a sec. And then just kind of a service overview, some of the benefits and features that we found that our customers have told us about. We've got some customers on, they're going to talk about that. There's also, you'll find a video link, which will take you to our website. And there is a provider there that walks us through the remote scribe workflow. He's using eClinicalWorks as the EMR, but it doesn't matter. We're up over 25 different EMRs right now. And then at the end, once we all hang up, everybody will be emailed a short survey. So we'd appreciate your participation in that. Without further ado, I am going to turn this over to Steven Sica. He's a Vice President of Business Development. And Steven, take it away.
Hey everybody, I appreciate everybody's time. Thank you for joining our webcast today. Also, big thanks to John and Dr. Elving-Dial over at JCH Healthcare. We'll be speaking with them shortly to get some of your questions answered. We've already received a whole bunch of questions about virtual scribing, and we're going to get right into it. So just want to start this off real quick with a quick poll just to get some idea for what everybody is doing here. So just curious to see, why everybody's attending today. So you're either attending this broadcast today because you are interested in virtual scribe services. This is a new concept to you and you're looking for information, or like me, your boss is making you do this. So pick your answer and we would appreciate that feedback. We'll close it here. Looks like 55%. This is a new concept. So perfect. Yeah, I mean, this is certainly a newer concept to most. I think during COVID, a lot of people had in-person scribes, and actually I'll get into one last poll here and then we'll get into the information. But a lot of practices had moved from in-person scribing to remote scribing during COVID and have since stuck with it. So it's becoming more and more commonplace than you would think. Last poll here. Your practice has previously used either of these services, and you can check all that apply. Virtual scribes, transcription dictation, live in-person scribes, or none of the above. See a bunch of different answers here. Okay, give another 10 seconds here. I lied, I'm gonna make it 7 seconds. Transcription dictation, okay, some live in-person scribes, and a third of you has never used any of these services. So this is completely brand new information for a lot of you, which is great, and we appreciate you joining for this. Just to show a little bit of information real quick about how a virtual scribe workflow looks. It's pretty simple. We do this in real time, and your providers are given a dedicated scribe, and this is all done in real time during the encounter as the patient is in the exam room. So by the time the patient leaves that exam room, about 95% of that chart is complete. It's logged directly into the EMR. We can queue up medications, lab orders, x-rays, anything that the provider needs. The provider simply just needs to look at that chart, make sure everything looks okay, and send any prescriptions off to the pharmacy. The scribes that we hire are experienced scribes. We hire in every specialty under the sun, and we train them on how to use your EMR. So you don't have to train them on how to do that. And a nice part is that they're not your employee either. You don't have to supply them with benefits. They don't drink your coffee. There's a lot of benefits to, sourcing out a service like this. It's a very light lift for IT departments. There's really not a whole heck of a lot to do here other than downloading an application. If you can download Skype or Zoom to your computer. We don't use Skype. We don't, just for an example. But if you can do that, you can certainly get started with a virtual scribe service. So we just connect through audio over a platform. One that we worked with a lot of success with is called VC. Very simple, very easy to use, or we can integrate with your instance of Zoom, Microsoft Teams. Our scribes are based both here in the United States and offshore. We do this to accommodate all budgets, so we can provide service for anyone, anywhere, and we offer full and part-time service as well. And finally, specific to ScribeEMR is we don't stick anybody into any kind of unreasonable long-term contract. So you're really just paying for what you use. It's not a huge leap of faith to get involved. You can get started real easily, and it's just real simple. It's real simple to get going, and take this pressure off of your providers really as soon as possible. So I want to introduce our guest, Mr. John Giertz. John Giertz is Vice President of Physician Service over at JCH Healthcare. John, how are you?
I'm great, Steve. How about yourself?
We're doing great. Thank you very much. I am going to moderate some questions that we have coming in, and also for the attendees in the web chat or the webinar right now, if you would like to submit additional questions, just go to the questions tab of the GoToWebinar. You can submit those questions. We will get to as many as we possibly can over the next 20 minutes or so. If there are any questions that went unanswered, something that we just couldn't get to for time reasons, we can certainly reach out to you, or we could set up another quick call where we can answer those questions for you. I'm going to take myself off of video here and go into moderation mode here. But John, if you would, please introduce yourself to the attendees, and just give us a little intro here, please.
So hello everyone. My name is John Giertz. I've been a administrator or VP in healthcare since 1998, and I've been on the private side. I've been with a couple integrated delivery systems. I've worked with Dr. Elving since 2004, and as her volumes increased and several volumes of other physicians increased, we had once we went on to the EMR, we started introducing scribes, and they were in-person scribes. And as time went on, it became more difficult to train them. There was a long training period to get them up to speed. We had, when they would call off, we wouldn't necessarily have someone to be able to cover them. And so here's this full schedule ready to go and no scribe. And it would be, it would make for a really challenging day for the physician. In many cases, we'd offload patients, so there's decreased patient satisfaction. And then in addition, I don't know the size of all your exam rooms, but most of our exam rooms are typical size, and there's just not a lot of room in there. And as you're in there, and I'll let Dr. Elving talk about that change, but certainly we've noticed a significant difference in the benefit to being able to have the virtual scribes as opposed to the in-person. And then finally, costs, staffing were becoming harder and harder to find when they did move on. And so this solution allowed us, for the 4 scribes that we use in one of our clinics, to be able to replace the in-person scribes with 4 virtual scribes and add a much needed phone triage nurse position. So those are our benefits, really, kind of in a nutshell.
Yeah, that's really good information. We appreciate the intro there. If we could just get into, I guess, the beginning of your time working with virtual scribes. Not so much the beginning, but let's go into your day. So what does your day look like starting with your virtual scribes?
Steve, that question is probably best introduced to Dr. Elving, because she uses it every day. I helped, I found you guys, so I'm still waiting for my finder's fee. But she is here, so why don't we introduce her? And I think that's a perfect one for her to tee up.
Yeah, Dr. Elving-Dial, welcome. If you could give us a quick intro, we'd appreciate it.
Sure. So I'm Christy Elving-Dial, and I've been in family practice for over 20 years. So I was used to paper charts and then the integration to the wonderful computer and the required documentation. And that's actually, I think, part of why we started using Scribes in the beginning, was to satisfy all those reminders and the bullet points and all those things that, I'd really like to just be a doctor and not have to worry about all that stuff. And I had several different live scribes. Yeah, and when they called off, your whole day was messed up. Never mind the fact that sometimes patients would kick them out because they, didn't want somebody else in the room or what have you, different things. You didn't have to worry about them yawning or scooting or typing when you've got a virtual scribe. So when we switched to virtual scribe about 2 years ago, well, it was actually over 2 years ago because I've had SID for over 2 years. It was actually a pretty smooth transition because when you start your day, so I come in, I turn on my computer, I log into our system, log into the VC system, and SID is usually right there waiting. If I've gotten, somebody interrupt me or whatever, he'll call me instead of me calling him. And on the VC, you just push a little button and you hear it like ringing. And if we're busy right out of the chute, we just start going. If we've got a few minutes, we might say, how's your day going? Did you sleep all right? He likes to play badminton, that kind of thing. And I know Dr. Palchev kind of reviews like his day with his scribe before he keeps going. But then, we go right in to see the first patient. When we see the first patient, I'm not at my computer typing a bunch of stuff. I'm looking at my patient, which they love and I love. And you can do it different ways. You can dictate to him or whatever, but SID just listens to what the patient is saying and writes it all down. He also then, if I say, oh, okay, well, we're going to stop your lisinopril. I'm very particular about my charts. And so I have him, he writes at the bottom, you are stopping your lisinopril, starting after today, or, wherever I say, or if we're starting a new medicine, he'll say, okay, we're adding lisinopril for your blood pressure. And those are all things that I would write down for my patient because nobody remembers anything when they leave the room. But now he does it. And so that saves me so much more time not having to do that. If I refer somebody to counseling, he has, we have a script and he, puts all those names and numbers down in the bottom. Or, if I'm just telling them a cheap place to get some product they need. The other thing is he orders my CAT scans, my x-rays, does all the referrals, does all that stuff. The only thing he absolutely cannot do is prescribe medicine, which is totally fine. That he shouldn't, if I say lisinopril, I should be the one to send that prescription, which is fine. Now I'm also very weird about my labs, so I don't have him order labs. I know Dr. Palchev and Dr. Krancer do have their scribes order labs, so it's just kind of what is up with you. Now, if he has a question about something I want or something I'm saying on VC, I hear a little noise. You can turn the noise off, do it different ways, but I hear a noise and I pull it up and he'll say, was that left foot or right foot? Because as I'm talking to the patient, I'll say, oh, we're looking at your left knee here and I see, you're tender on your medial collateral ligament. And so that's where he gets his documentation. And, oh, your right ear has some fluid behind it, or it's red, and instead of me dictating those things to him or to the computer later, he gets it as I'm saying it. So I am just talking the whole time I'm, doing my exam. So he's got what's going on. You have crackles in your right lower lobe. And so that, is a pretty smooth process. And then I'm trying to think of all the things that he does. Simple things like the suicide risk assessment. The patient does their PHQ-9 and then he puts that in, which then when I see it on the screen, it reminds me, for sure to ask for those kinds of things. And smoking cessation, because I tell him, oh, you need to stop smoking. So then, he gets that all documented in there. And I'm pretty confident that our scores for that kind of thing has just done nothing but go up, and we're meeting all our goals.
Yeah, Steve, when you start a question with John and Dr. Elving, we can go for a while. So,
hey, this is exactly what we're looking for. This is
all
great.
right.
They want to hear from you guys, not us. So this is what it's all about.
So to answer Dr. Elving's questions, she's first of all, she's a great physician, but we have a physician of the year. We have 55 total providers, and we have a physician of the year and a AHP of the year. And Dr. Elving has been 3 out of the last 4 years our physician of the year, and that's based on customer service. We use a third party, to complete a CG cap survey on our patients. It has to do with quality and some other intangibles. But when Dr. Elving talked about quality, she's one of our top quality bonus. Our average score is somewhere in the upper 70s or lower 80s. She's at upper 90s and 100. And a lot of that has to do with, again, her Scribe and her relationship. They really work hard to satisfy all of those CQMs, and it makes the pay for performance side easier. We're part of an ACO, so her scores really help the group overall. And then, Dr. Elving mentioned that other component of having another person in the exam room when you're talking about, more intimate things or just in general. And there's obviously a very strong bond between a patient and a physician. And so having that removed by having that third person that's there that may not know them as well has really, I think, helped her achieve, and again, be at the top of the level as far as our CG cap scores. She's in the 90th percentile on a continual basis. Mm-hmm. So it's, in our minds, it's checking all of the boxes. It's easy. You mentioned IT connectivity. That was very easy for us. We purchased these SAM, I believe is the name, SANSOM. They're external mics, so they work really well. They sit on top of the laptop. They plug in through USB. You guys recommended those to us. The connection through VC is very easy. Yeah. We use all overseas Scribes. We gave access through VPN to your Scribes. It's gone really well. And then as far as when we launched, we were working, this was a goal of ours in FY 2020. And, here comes this thing called COVID. And, who knew that we were going to have such a staffing ongoing issue like we have the last 2 years. So, we've reached points just like every group, I'm sure, just trying to have enough staff to cover providers. So knowing that we didn't have to pull Scribes because they were already there. They were there virtually for us. And your teams met that challenge. We've done really well on, Dr. Elving was our first to go. Mm-hmm. We went ahead and started her in March as planned. In fact,
March 17th.
Yeah, I have a feeling, I think your external trainer, we were probably the last in-person training session for quite a while. Mm-hmm. She left and made it back in time before things really started shutting down. But it went really well. We delayed the other physicians because volumes really kind of plummeted. But then as volumes picked back up in May and especially June for us, we got the Scribes back on board, and we've been going strong ever since.
And interestingly, with COVID, you do a lot of telemedicine visits. So I would put the patient on speakerphone in my office to do those visits, and then Sid would still scribe just like usual. But the best part is he always remembered to put when the visit started and what time the visit ended, because I always forgot that part. And he'd be like, "No worries, I got it." And then a couple weeks ago, our computer completely crashed, our EHR system. But of course, we still had internet. And so we were frustrated. But the nice thing is Sid took all his notes down on like a Word document. And then when the computer came up 4 hours later, it was great. 4 hours later, he literally had all the notes already because he had saved it all in a Word document. So I didn't have to dictate or anything else. He's like, don't worry, I got it. You go to lunch, I'll take care of this. And that's what happened. That was wonderful. I'm trying to think of other little things where he saves my butt. His spelling is way better than mine.
Well, Dr. Elving, I do have a question. I have somebody who actually has two questions, and we can kind of knock those out with one stone here. They're wondering if we work with the next-gen EMR. Yes, we do. We basically integrate with any EMR that you have, whether it be Epic, next-gen, eClinicalWorks, anything. It doesn't really matter to us at this point. We've seen them all, and we can certainly integrate, no problem. And a follow-up question from the same individual, and you touched up on it a little bit, and maybe we could talk about this a little bit more because it is a common question we get, are about patients being comfortable. And you mentioned this a little bit, but what have you seen from your patients, if you can explain, going back in time to when you had one of your scribes before you moved them into a different role, what has the difference been having that third party in the room as opposed to having a virtual scribe?
It is absolutely night and day, in my opinion. I had several different scribes, but first, just having that third person. We're in a small town, so that person knew them, knew their family, that kind of thing. And they're always like, now this is confidential, right? And they know with me that it is, but they always worry about that third person going home and telling the world. And even if it's not anything private, particularly private. And just the fact that somebody else is in the room, somebody else to walk around, I had one that did not sleep well, and so she yawned a lot. And there's nothing more embarrassing than when somebody else in the room, you're having a serious conversation, they're yawning. You're like, really? So, that kind of thing. So I have a sign in my room that says your visit is being recorded by a remote scribe or something like that. And there's a little microphone on my computer. And I've had some people ask me about it. And they're like, is somebody listening in? And I go, probably the FBI. I said, no, there is somebody listening in, and they're remote. And they kind of give me a look, and I go, but he's in India, so if he hears your personal information, trust me, he doesn't care, and he doesn't know any of your friends. And they always just laugh and keep going. Now, I've had a couple of people who then had a full-on conversation with Sid asking about stuff that was going on in India, and I'm like, okay, come back to the visit. You can talk to Sid later if you want, be friends on Facebook. But nobody has had an issue with it. Nobody said, can you turn that off? Where a physical scribe, I had at least one patient a day who would ask them to leave, just because they didn't care for them to be in the room. So,
and again, just from a logistics standpoint, it just crowded out the room.
Yeah.
It's already with an exam table, and if I could have redesigned the space, I'd make for bigger exam rooms, more luxurious. But the space was designed, with some EMR components put in mind, but really it's gone really, really well. Operationally, it's gone really well from a financial standpoint, again, to be able to not lose production when a scribe calls off or quits and we have to throttle back that production, to be able to meet CQMs, get some of those extra pay for performance dollars to, in our clinic setting, we were able to roll those savings into getting an additional nurse triage, which again allowed for increased production with less work on the MAs, to be able to, they could focus on really the patients at hand. So for us, a lot of operational gains, and then to know that Dr. Elving, and the patients have it's gone really well is really that icing on the cake. So.
What would you say is, I'm seeing a lot of questions about this, in terms of getting to a proficient level with your Scribe. About how long would you say that took for you specifically?
Honestly, so when I have a physical Scribe, it takes a lot longer. They're just used to doing this, so that's their thing. John and I were talking about this yesterday. 4 to 6 weeks at the most, and that's like proficient. I mean, he followed, virtually my Scribe around for 2 days, and then he was on his own, and it really wasn't a big deal. The biggest thing was learning my favorite things, how I want things done, and it wasn't learning the system at all. It was learning my preferences and what I wanted. And sometimes it takes that long to see everything that you might need to know about. So
I would agree. And in fact, the way your organization set it up for us, with us having four Scribes, Sid, who's working with Dr. Elving, became the kind of the lead, if you will, of the other Scribes. So then, as we knew they were eventually coming on board, they were able to train with him, or he was able to help train them, however you want to look at it,
right.
And learn at least the Entergy component. That's what we use is the Greenway Energy EHR. And so then he was able to, and the other Scribes were then, it was more about just learning then physician practice, preference, style, and things like that. We have a lot of standardized templates, but we still have a lot of individualized as well.
We have some questions coming in regarding the training process for the ScribeEMR Scribes. I'll cover that briefly. We do hire Scribes with experience. We're looking for experienced Scribes in a variety of different specialties. I call it our bullpen. So we're looking for Scribes in every specialty that you can imagine. What we do then is we put them through an 8-week training program where towards the end of that training, we already identified that Scribe to go to work for, say a cardiologist using Epic. So what we'll do is we'll find one of those Scribes that has that background in cardiology. If they have experience in Epic, great. If not, we can teach them over the last couple of weeks of that time. But what we find is more important than that is for the Scribe to get to know the provider and their preferences, their templates, which obviously they'll learn on the job, when they go live with the provider. And real quick to add to that, the first week or so where the Scribe is going live with the provider, they spend a couple of days shadowing the provider so they can see, what their preferences are, and that by the end of that first week, they're in the charts, doing about every other chart, and then maybe, ramping up to 100% by the end of that first week or the beginning of the second week. And like Dr. Elving had mentioned, really you can expect proficiency, in about 3 to 4 weeks, where, this is somebody that, knows your practice, and things just get better from there. A question here, which I think is a really good one, is what have you gained from working with ScribeEMR? And this could be, both on the business end of things, personally, what have you gained? Kind of leave that open-ended for you guys.
Time. I've gained time.
Time and a smile. I have, Dr. Elving has a great personality. I would say that if she wasn't here, but she's, the stress that comes. I hope you don't mind me sharing this, but I was off site. I got a call from Dr. Elving, and she said, "I'm exhausted." This was a couple. Do you remember this call? I was in Decatur, Illinois, but she was exhausted. And she's very active in the community, and she wants the best. She makes sure patients get every question answered. And we needed to clear the schedule for the day and get her home and let her have a
mental health day.
Yeah, mental health day. And that's I believe her Scribe had we were in the process of dealing with some disciplinary issues with her Scribe, between calling off and other things. It's never the easiest. As a health system, we have a very strong HR system, disciplinary system progressive that you would expect. And it takes a while to move sometimes employees through that call off and are just, they're unreliable. And the yawning is just not acceptable in our minds because we do have coffee. And so we, when I look back on herself and just how this has really been life-changing, I check in with them and I ask them how things are going, how the service is going, different things like that. And out of the blue, when our system, our EHR was down, and the PM actually was down as well for about 2.5 hours. Normally, we're all paper at that point. We don't even know the schedules. It doesn't happen. It's only happened once in a great while.
It was 2 weeks ago.
Yeah, but to get an email from her and because we knew this webinar was coming up, but just to let everyone know that her day, she didn't skip a beat. Was actually able to still listen in and catch things up, whereas everybody else loads everything onto paper, maybe puts C attached, but then if they want the data structured back in, it's got to be restructured and reloaded or keyed back in. So time, satisfaction, burnout, production gains, everything is shifting to quality in the industry. You've got to be able to prove that you cover everything, satisfy all of the measures that are suspect medical conditions or whatever it may be. Dr. Elving does a great job with wellness visits, and those things go really well. And there's a lot of things that are associated with all of that to make sure it goes well. We do Medicare wellness visits. We do everything, and it's going really well.
Yeah.
I'd like to throw this one over to Terry. We'll bring Terry back in on this one. There's a question that came in regarding the scribes going through some old medical records.
So I think the best story that I recall is Advent Health. Obviously one of our larger customers. We do a good deal of their orthopods down in Palm Coast, which is Daytona Beach up to Jacksonville. And obviously orthopods spend half of their day doing surgery and the other half in clinic. And so one of the quality measures, and we talked a little bit about quality measures this afternoon, one of their measures they were reporting on was women's health. And so Advent Health, for the most part, was Athena Health, which is Athena Health EMR. And the inpatient side was Cerner. So what the execs at Advent Health asked us to do is when the physicians were in the OR doing surgeries, the scribes would go into Cerner and look at the schedule in Athena Health, and then any of the female patients, they'd go into Cerner and they would pull down anything to do with women's health. And so DEXA scans, PAPs, mammos, any of those things, then we pull those down and we push them back up into Athena, and that allowed Advent Health to report on women's health as a measure. And just to add on, then Advent Health 3 weeks ago went over to Epic. So just to give you some elasticity on our background, Epic, Athena, the folks here, Epic, Athena, Cerner. So there was 3 EMRs that we covered right there. So hope that answered the question.
Yeah, thank you very much. And also, just going through some more of the questions here, Terry, if you could, cover this one as well in terms of the scribes pre-charting along with the live scribing. If you could discuss that a little bit.
There's a couple of things with the pre-charting. So number one, we're all having staffing issues here in the States. And so what I'm seeing lately is we've expanded from scribing over to virtual assistant, which means so we have folks that are now taking appointments, prior authorizations, insurance eligibility, all of that stuff. but one of my customers in South Florida is Associates MD, so very large multidisciplinary practice, and they have a lot of patients hospitalized, and then their eClinical works, and so they have a module in their kind of case management where they can see, or we can see the patients that are being discharged from the local hospitals down there. And so what we do for those folks is actually go and request the medical records from the inpatient visit. And I say that because a lot of our folks are now having to go out and get labs and studies and things like that. Now, our scribes do not have telephones, so they can't call. So it's a little bit different program. We get into the the high volume of tracking down studies and whatnot. But pre-charting starts for the scribe about an hour ahead of time. And what they're doing is seeing who's coming in for the day. If it's a new patient, do we have what we need? If it's a follow-up, what did we do last time? So maybe it was a chronic sinusitis and we did a CAT scan of the sinuses. So that's where the scribes are looking for what's in the record, and then starting to build the charts for the day. And what that does is it keeps the providers out of having to navigate and just presents it to them, because it's all about efficiency.
One question that just came in here that I'll answer this one here is about the quantity of providers. They have 26 providers, but they need 26 scribes. And what do they do when the provider is in between patients? So that's a really good question. So all of these scribes are dedicated scribes to the individual provider. So the short answer is yes, each provider would have their own scribe, with the caveat that if you have some part-time providers, or maybe you have some surgeons that are in clinic half the week and in surgery the other half of the week, you would have the opportunity to share one full-time scribe with a couple of part-time providers. So you can go that way there as well. I'll ask you guys as well, Dr. Elving and Mr. Giertz, in terms of I don't want to go too much into the actual pricing and the cost. That's a conversation for another day. But if you could put just an idea in terms of return on investment for this service, if you could kind of compare that to, what it might cost you to have in-person scribes as opposed to, these virtual scribes. How long do you think it took you to receive or to realize ROI on this investment?
It was honestly for us. See, we already had it budgeted, so we may be a little different case study than some of you, but we already had 4 in-person scribes. We knew what they were costing. We knew their benefits. We knew what our production days looked like with those into the picture. We had pain points of having too many calls going back to the MA teams. Well, so you're not live answering as many calls as you could. So now we're able to provide a higher satisfaction to our patients and get those calls taken care of and addressed without it sitting in a voicemail. And in the case of Dr. Elving, so she would have a rooming MA and who was in between times checking tasks and working phones, and then also the scribe. And when the scribe wasn't around, that was probably one of our biggest fears. Well, when the scribe isn't in the room, they're also helping do things. So I had to sell this concept. Dr. Elving was the first to say, this is a great concept, I'm going on it. I had another one of my very high volume physicians say, well, I'm gonna lose something because my scribe does X, Y, and Z. And I'm talking about.
He had 3 providers, or he had 3 MAs. Now he has 1.
Yeah, he wanted 10 MAs if we could give him 10. So I would say the cost is like 2/3 of at least. It is, and again, as in our perspective, we're not in a metropolitan area, but we are also 20 minutes from the metro east of St. Louis. So while we are a little bit more rural in our size of our town and county, we're 20 minutes away. So employees are going to leave. That's what we constantly battle. If they want to go make $3-4 more an hour, they can drive 40 minutes to St. Louis, or even a little less for a little less, and be in Alton or Godfrey.
Something else we didn't mention is, so I have a rooming MA who's also answering the phones and doing messages and stuff. And then you had the scribe MA who's in the room. And yeah, in between patients, you might have a little downtime. So then there was always that, you're not doing as much as I'm doing kind of thing. And now with Sid, there's no question. You know, he does his job, and they don't sit and bicker about you not doing enough work.
But to answer what I would recommend to those that may not even have scribes, I would recommend, what are you able to do in your current state? So in terms of production, and how can you get those extra 2 to 3 visits a day, and even if you broke even. So I would look at it more as, here's the cost for the scribe, and then work backwards. How many visits is it going to take? Where can we put one in the morning and one in the afternoon, and get all of that efficiency for every one of the visits? The physician, the AHPs, whoever, are they going to be able to do that, and then know that most of their chart is prepped and completed, and can, at the end of the day, get out of there at a much more decent time? There's always follow-up, but
we close a lot of them after the visit. That's the goal. Close them after the visit.
And Dr. Elving, how many patients do you see on average per day?
20. Now,
20.
Not huge, because I take a lot of time with my patients, but I was seeing like 16, which John didn't like.
Well, that's a big
definitely increased. And I do, less charting at home, and I got out of there at 5 on Monday. That's a Monday.
She also supervises 3, 8, maybe 4 AHPs. I can't remember how many you got now.
I got a lot.
She has 2 AHPs in the clinic. One
nursing home.
One she supervises for nursing home, and then she oversees our MAC clinic.
And Carrollton.
And she oversees our Carrollton.
That's 5.
So so she's doing a lot of. We have 15 clinics. We have 7 primary care offices, but we have like any system and group, you try to pull as many levers and as you can, and so
helped a lot.
Yeah, while 20 may be deceiving, that also means there's a lot of AHPs out there, which in the marketplace, it's harder and harder to find physicians, and they extend the practice. Dr. Elving, obviously, by what you just heard, has one of our biggest practices when you count total number of patient population. So.
Yeah, and certainly we talk to, C-suite executives for different healthcare organizations, providers, office staff, and, we find that everybody has their own needs. Providers are looking to, gain some of that time back, Dr. Elving, like you had mentioned. There's nothing more valuable than that. Office staff is tired of chasing down providers to complete out charts. The CFOs of the world just want to increase reimbursement, and we get it. We talk to everybody, and we like to think that we're one of those organizations out there that kind of help all of those different roles out with the same thing. So I'll kind of wrap things up here. And again, we really appreciate your time, Dr. Elving, John, Giertz. Thank you very much. Is there any, I want to make sure that I give you the opportunity to mention anything else that, that maybe you'd like to mention towards the end of this webinar here.
The only couple of things I would mention, so, 20 visits, but I can also tell you they are not 99212. They are generally 99214, and
complex.
Even on auditing, that's the way they bill out. So, then there was a question somebody had asked about, because Sid's in India, is there a language barrier? The only couple things, it's been tater tots. He thought it was tater tarts, but and he wasn't sure what biscuits and gravy was, but he wrote it down anyway. So it's only been weird little things like that. But generally, I'll be sitting there and I'll be like, "What is that? What is?" And he'll actually remind me what the word is or whatever. He's very, very good at that. And if there's something that I can explain, because he can see my screen, so tater tots, for instance, that's not a normal example, but or if I'm referring to a cardiologist, I can look it up on Google and bring it up, and then he has the name and all that stuff, and I walk away and he sends it to referrals. But I could show him a picture of tater tots so he knew what those were. So that helps, because he does see my screen and what I'm doing. And yeah, spelling is my big help. But the other thing is, if he's going along and he's not sure what I mean, he'll put in an asterisk in the HPI or plane or wherever. And so when I see the 2 asterisks, then I know I need to clarify something for him. But I mean, I wouldn't enjoy my work near enough if Sid weren't there to help me.
Here's something I've noticed, because I start my day often at Dr. Elving's clinic. It's our largest single clinic, and I'm there most mornings, and every so often I'm in your office when you're starting up your laptop. And Dr. Elving has a fantastic relationship with her scribe, if you couldn't tell. And when I asked even the more skeptical physician, if you will, because he wanted 15 staff, his words were, I'm very pleasantly surprised. And again, at one point when we were in he had 3 MAs. I forgot that. That's how many.
He had 3.
3, and he has 1, and the Scribe. So when you talk a return on investment, that's pretty extreme. And again, I just, like any new venture that requires some expenditure, the capital expenditure is very small. Your microphones aren't $40-50. They're not very much, and giving someone VPN access, and as long as you have all those systems in place, really isn't a big deal. But there's obviously an operating expense as it relates to having the scribes. And for us, again, it was very easy. We kept our production the same, if not bolstered it, and we had more reliability. We got rid of the call-offs and the decreased production when that happened. The patient satisfaction has been sky high. And Dr. Elving mentioned most of her visits being 99214s. So while the documentation did simplify in January of 2021 to help out some physicians, we made sure that Dr. Elving's been at 100% in our coding audits for a long time. So we use a third party again to provide an external coding audit to make sure our levels of service and satisfy those CMS requirements, as well as to make sure our physicians are documenting properly and giving themselves the credit or not overcoding. And so that relationship, while Dr. Elving does all of the coding, but knowing that all those components are there, again, you heard reminders of telehealth. They're along for the ride. We use Energy, and we use Doxy.me as an additional party. We launched, to tell you how adaptive the company is, we use a third-party application called Check and Assist. And as we launched that was easy for the scribes to pick up. They saw the forms come in. MAs were able to do their thing, and we gained a further workflow, especially for the rooming MAs, to have that data come in structured, as well as the registration gains. So my job as a VP of Physician Services is to try to, I'm the snowplow. I try to clear the road for the providers to be able to do what they need to do and provide a great patient experience. And it's important that our staff have a positive work experience as well, because if they are, then they're going to provide better service to the patients and to the physicians. So our people are very important to us, and I'm sure they are to your organization. And we consider your the folks at with ScribeEMR as part of our staff and part of our team.
Well, John, Dr. Elving-Dial, thank you so much. We really appreciate your time, all of your insights into what it's like working with virtual scribes. I just wanted to also thank our audience for joining us for this webcast today. If you would like any additional information on either signing up for service, pricing questions, or anything at all, you can contact us at one of the phone numbers, email addresses, websites that you see on the screen. I was going to throw up Terry's TikTok, but he told me not to. So if you'd like to screenshot that to get in touch with us, please feel free to do so. Again, thank you to our panelists, Mr. John Giertz, Dr. Elving-Dial of JCH Healthcare in Jerseyville, Illinois. Thank you very much. We appreciate it.
Have a great day, everyone. Good
Thank
luck.
you. Have a great day.
Bye.